Migraine is much more prevalent in females than in males. This can be due to the intrinsic nature of migraine. Migraine is a useless hyperfunction of the brain defense, and female brain is hyperactive and has a higher connection speed compared to the male one. We know that females have more frequent migraines compared to males, but their migraines are also usually more severe. Furthermore, females have harder to treat migraines during their months because those who are in their reproductive life easily recognize that menstrual-related migraines are much harder to be treated, are more disabling, and respond less to acute treatment. And also, they have a trend to remain even when the patient follows a proper preventive treatment. We should approach to female migraine in a multidisciplinary manner. Why? Because we know that, for example, females may need hormones, may use oral contraception or other kind, not oral contraception, then they may deserve, following menopause, again, hormonal supplementation, because they may have residual migraine attacks at the beginning of their pregnancy or during breastfeeding. So we should work in contact with gynecologists, for example, but also with pharmacologists, sometimes with endocrinologists, and sometimes also with oncologists, because we know that, for example, when a female patient has a breast cancer and receives a hormonal treatment which is aimed at blocking the ovarian function, the headache and migraine may worsen. So there are several women inside the single women across her lifespan. And so the neurologist, the headache specialist, should be aware that the cooperation with other colleagues is needed, sometimes mandatory, to provide to the female patient the best treatment, the safer treatment, the most tolerated treatment during her life. For example, we should inform gynecologists if the patient is affected with migraine aura that estrogen should be avoided. This is just one single example of cooperation.